The CDK4/6 inhibitors, some of them can come from your local pharmacy, some can come from a specialty pharmacy, and it's really very much insurance dependent how it's going to get dispensed. And so, I'll say I don't usually know this ahead of time, so what I do is I prescribe the drug and I tell the patient that, I've sent the prescription to our pharmacy, but then in our system we have a plan in place that it gets reviewed by our pharmacy to know how the drug could get dispensed, and then that gets communicated back to us to let us know that if they were able to dispense it or if it had to get sent out to the specialty pharmacy. I think that communication piece again is critical because the patient then needs to know how they're going to get their drug and then when to expect it. And so, it is really just so dependent on each person's plan with each different drug that it isn't something that we usually can keep track of. I will say when it comes from a specialty pharmacy, it does create a little bit of a delay because then it has to get sent from the specialty pharmacy to the patient as opposed to them just picking it up the same day I prescribed it at our own pharmacy. So, that again has to be taken into account when scheduling monitoring for the patient and follow-up.
I think we rely on our staff, our nursing staff, to communicate with them and to overcome that barrier of not seeing them so frequently. And we have a great team of program nurses that help us do that. In the beginning as well, we are seeing them every 2 weeks, which is not terribly different than any other schedule. So when they're initiating therapy, we are keeping a close eye on them and talking to them every few weeks face to face. And I think, again, it's about setting expectations. A lot of these patients haven't been coming to the clinic very frequently before starting this, and it is new. So when there's been a change, they like to see us more frequently, and questions come up as time goes on. And so those few visits that are clustered in the beginning can be really helpful to get them to understand what to expect.
So certainly one of the challenges with CDK4/6 inhibitors as opposed to just giving endocrine therapy alone is that it does require more monitoring than we certainly had been doing with endocrine treatment by itself. So specifically for all three agents, we do need to monitor a CBC with differential on day 1, so cycle 1, day 1, cycle 1, day 15, cycle 2, day 1, cycle 2, day 15, and then when we start our new cycle, cycle 3. Thereafter, usually the monitoring can get loosened up to every 2-ish months as people go on, depending on what side effects they may have experienced. There are slightly different monitoring requirements for each agent. So specifically for abemaciclib and ribociclib, one must also monitor liver function tests. So that must also be done every 2 weeks for the first 2 months. And then specifically for ribociclib, one must also monitor QTC. So one must get an EKG on cycle 1, day 1, cycle 1, day 15, and cycle 2, day 1. And that's really looking for any prolongation in the QTC, which is associated potentially with ribociclib. So with all three agents, again, there really is some form of monitoring every 2 weeks for the first 2 months. I think the only other warning that one has to keep in mind is that's a little unique, is that abemaciclib has been associated with a slightly increased risk of developing a venous thromboembolism. So that is something to keep in mind. Certainly all our patients with metastatic breast cancer are at higher risk for developing a clot, but it seemed like it was at a slightly higher rate than we would have seen just with a patient with metastatic disease.
All three drugs cause fatigue, and I always counsel patients that you will probably experience some fatigue, though not so much that you won't be able to live your life pretty normally. There are exceptions to that. There are some patients that have grade 3 or rarely grade 4 fatigue, but I always tell people there's always the option for a dose reduction. And one of the exciting things that Sarah mentioned was with abemaciclib, how the when dose reduced for diarrhea, which is separate, but that there wasn't a difference in progression-free survival, which I think we can't always tell people. People always have that question with any therapy. In terms of diarrhea management, with abemaciclib in particular, I tell people chances are you will get this. There's a small percentage of patients that don't get diarrhea, but that once we know how bad your diarrhea will be, we can titrate the loperamide dosing to control it. And I think we're 95% or more successful in managing side effects overall to make these drugs tolerable and allow people to live their life as close to normal as they can.
And I think, also we certainly do see issues with neutropenia, with palbociclib and ribociclib. About 60% of patients end up needing dose holds or dose reductions. But that's all very manageable. And like Lindsay was saying, the first 2 months are really a time when we're sort of feeling out how they're going to tolerate it. And once they usually pass that, we've usually done our dose hold and dose modification. And so usually they're on a pretty stable dose thereafter, and again, usually pretty manageable. I think also important to note that while these drugs do cause a lot of neutropenia, it's very rare they cause infectious complications. So there's only about a 1 to 2% rate of febrile neutropenia with these agents, as a very different than what we see with chemotherapy. So, again, usually this is something that can be well managed without serious complications. I think, again, the only other thing that we sometimes see is some elevation in liver enzymes, which, again, is usually pretty mild and not something that I'm usually having to do dose holds and dose reductions for. And then finally, I think the issue with regards to QTC monitoring with ribociclib, I think it's important to keep in mind if you're giving other agents too that may be prolonging QTC simultaneously. So that is a little complicated. You have to just be mindful of what agents that patient may also be on. So generally our patients, we usually like to see them every 2 weeks for the first 2 months if we can, if they don't live, a far distance away from us. Since they would be coming in for a lab check anyway, we usually will see them to assess what side effects they've had and see if they do need any dose holds or dose reductions during that time frame. So that's either with Lindsay or I for, again, those first 2 months. Thereafter, their patients are often seeing us usually every couple months. It also depends how they seem to be responding to therapy. If we see that they're tolerating treatment well and aren't having new symptoms from their underlying disease, certainly those visits can get spaced out. And we usually like to time them with time points also of restaging scans along the way. Many of these patients also need bone modifying agents, whether it's zoledronic acid or denosumab. And so some of these patients are coming in either monthly or every 3 months, depending on what agent they're getting for those treatments in addition. And so if they're coming in for those treatments, we'll often see them in conjunction with that too.